Stay blessed. So, my beloveds, your big oral exam, state exam, and your question is endometriosis and adenomyosis. Let's go. Take your pens, papers, and let's go. So, endometriosis is a condition where tissue similar to the endometrium, lining of the uterus, grows outside the uterine cavity, most commonly in the pelvic cavity. About etiology, so retrograde menstruation. The most widely accepted theory is that menstruated blood flows backward through the fallopian tubes into the pelvic cavity, carrying endometrial cells that implant on other structures. So this is a theory, of course, and a widely accepted theory. Is it really like that or not? No idea. Not sure. Anyway, so retrograde menstruation. Genetic factors, so-called genetic predisposition. Family history increases risk, suggesting a genetic predisposition. What else? Immunological factors. Defective immune surveillance may fail to clear displaced endometrial tissue. Yes, why not? Hormonal influence. Estrogen particularly promotes the growth of endometrial tissue outside the uterus. Environmental factors. Environmental toxins may also play a role in the development of endometriosis. About symptoms. Chronic pelvic pain often linked to the menstrual cycle and may worsen with intercourse, bowel movements, or urination. Dysmenorrhea, severe menstrual cramps due to the growth of endometrial tissue outside the uterus. Dyspareunia, pain during intercourse. Infertility. Approximately 30–50% of women with endometriosis experience infertility. Gastrointestinal symptoms like nausea, bloating, and changes in bowel habits, particularly during menstruation. No, maybe it's a toxicosis, toxic signs. Urinary symptoms, painful urination or blood in the urine during menstruation. Fatigue. Chronic pelvic pain and inflammation may lead to fatigue. May, why not? So symptoms: chronic pelvic pain, dysmenorrhea, dyspareunia, infertility, GI symptoms, urinary symptoms, fatigue. About diagnosis, clinical history and symptoms. Women of reproductive age with chronic pelvic pain and dysmenorrhea should be evaluated for endometriosis. Pelvic examination may reveal tenderness in the pelvic region or nodules in the posterior cul-de-sac, pouch of Douglas, or other areas. Cul-de-sac in French, pouch of Douglas. Ultrasound, transvaginal, up to you how to pronounce transvaginal, useful for identifying endometriomas, ovarian cysts associated with endometriosis, endometrioma, ovarian cysts associated with endometriosis. However, it may not detect smaller lesions outside the ovaries. It means ultrasound. MRI can be helpful in diagnosing deep infiltrating endometriosis and mapping the extent of disease. Laparoscopy, the gold standard for diagnosis, allowing direct visualization of endometrial implants and confirming the diagnosis. Biopsy can also be performed. CA-125. Elevated levels may be seen, but it's not specific for endometriosis and can be elevated in other conditions such as ovarian cancer or fibroids. Management, medical treatment, NSAIDs, non-steroid anti-inflammatory drug, for example, ibuprofen, for pain relief associated with endometriosis. Hormonal therapy, so COX, combined oral contraceptives. COX, not another thing. COC, acronyms, to suppress menstruation and reduce pain. Progestins can shrink endometrial tissue and reduce pain. Examples include Depo-Provera or Mirena Mirena, IUD. These progestins can shrink endometrial tissue and reduce pain, and examples include Depo-Provera and Mirena or Mirena IUD. Hormonal-reducing, gonadotropin-releasing hormones, agonists, for example, leprolide, how to pronounce, induce a temporary menopause-like state, reducing estrogen production and suppressing, my beloveds, endometrial growth. Danazol, a synthetic androgen that suppresses ovarian function and endometrial growth. Aromatase inhibitors can reduce estrogen production in limiting the growth of endometrial tissue. Surgical treatment, laparoscopic excision, removal or cauterization of endometrial implants. It's considered the most effective option for patients with symptomatic endometriosis or those who are infertile. Laparoscopic excision. Hysterectomy, considered in severe cases, of course, where the other treatments have failed and fertility is not a concern. Removal of the uterus and sometimes the ovaries may be indicated, maybe. Fertility treatment, in vitro fertilization, IVF. For women with endometriosis-related infertility, laparoscopic surgery may improve fertility by removing endometrial lesions and adhesions. Adenomyosis. Adenomyosis is a condition in which the endometrial tissue grows into the muscular wall of the uterus, myometrium. This leads to uterine enlargement and can cause painful symptoms. So actually the exact cause of adenomyosis is unclear, like endometriosis. But theories include stem cell invasion. Endometrial stem cells may invade the myometrium during menstruation. Okay. Trauma or surgery, prior uterine surgery such as cesarean sections or dilation and curettage, DNC, may increase the risk of developing adenomyosis. Hormonal influence, estrogen may stimulate the growth of endometrial tissue into the myometrium. Risk factors of adenomyosis, it's a multiparity. Multiparity, it's a multiple pregnancies. Advanced age, previous uterine surgery, hormonal exposure, estrogen. There are risk factors, multiparity, advanced age, and previous uterine surgery. Hormonal exposure, estrogen. Symptoms, menorrhagia, heavy menstrual bleeding due to presence of endometrial tissue in the myometrium. Then about adenomyosis, dysmenorrhea, severe menstrual cramps often worsened by uterine contractions. Chronic pelvic pain, a dull, aching pain, often worsened during menstruation. Enlarged uterus may be palpated during pelvic exam. Infertility, in some cases, adenomyosis can contribute to infertility, though it's less commonly associated with infertility if we compare to endometriosis. Diagnosis. Of course, clinical history and symptoms. Women with menorrhagia, dysmenorrhea, and pelvic pain should. Menorrhagia, up to you to pronounce. Dysmenorrhea and pelvic pain should be evaluated for adenomyosis. Pelvic examination. An enlarged tender uterus may be palpated. Ultrasound, transvaginal ultrasound, is the first-line imaging modality. It may show an asymmetrical thickening of the myometrium or an heterogeneous appearance. MRI, the most accurate imaging modality for diagnosing adenomyosis. It can show myometrial cysts and characteristic stations. Myometrial cysts and characteristic stations during MRI. No, actually, it's the most accurate imaging modality, MRI. Hysteroscopy. We talk about diagnosis. Occasionally used to visualize the endometrial surface, although it's not commonly used for adenomyosis diagnosis. Yes. Histopathological diagnosis, typically confirmed only after hysterectomy, of course. Management, medical treatment for pain management, especially during menstruation, NSAIDs, non-steroid drugs, ibuprofen, etc. Hormonal therapy, similar to endometriosis treatment, hormonal therapies aim to suppress menstruation. COC, progestin or Mirena IUD to reduce bleeding and pain. GnRH agonists can suppress menstruation and reduce symptoms. Aromatase inhibitors may be used in certain cases to reduce symptoms. To reduce estrogen-dependent tissue growth, we can say in this manner. So aromatase inhibitors may be used in certain cases to reduce estrogen-dependent tissue growth. As surgical treatment, hysterectomy, the definitive treatment for women who do not wish to preserve fertility. Complete removal of the uterus can provide symptom relief. But we have to explain all this, not just they say we are sorry. Conservative surgery in rare cases, a myomectomy or partial excision of adenomyotic tissue may be attempted, although outcomes can vary. So largely sufficient for your excellent mark on a big board.